Awesome. So before we do get started, I just wanted to take a moment to recognize that this presentation is being held in collaboration with Pancreatic Cancer Canada in recognition of Pancreatic Cancer Awareness Month. So today's topic will be pancreatic cancer genetics, and we have with us Spring Holter for our talk today. So I am very, very pleased to introduce Spring today, who is with us. So Spring has a master's degree in human genetics and genetic counseling from the University of Michigan in 2005. And after graduating, she joined the Familial Gastrointestinal Cancer Registry at Mount Sinai Hospital, providing genetic services to patients and families with hereditary GI cancer syndromes. And she has become a leading expert in pancreatic cancer clinical genetics in Canada, and has also joined the University Health Network in 2021, and now focuses on providing genetic counseling services to patients and families with hepatobiliary pancreatic cancers. So Spring, I am so glad to have you here with us today, and thank you so much for your time. Oh, and we're just going to get you to unmute.
There we go. Sorry. I think I would know by now. Well, anyway, thank you to everybody at Wellspring and Pancreatic Cancer Canada for inviting me to talk about a topic that I think is very important to me and relevant to a lot of our patients and families right now. So we are going to go through, I have a bit of an outline, so I'll give you guys a basic information about genetics. We'll talk a little bit about the differences between different genetic testing. So whether we're assessing the hereditary or tumor side of things. We'll talk about what we're looking for in families, what genes are associated with an increased risk for pancreatic cancer, as well as what we don't know in terms of familial pancreatic cancer, risk for family members and screening, and how people can actually get referred for testing. So I'm sure a lot of people have some basic genetics backgrounds. You see things on TV and whatnot, but just as an intro, your genes are just instructions for your body. They tell you how to grow and develop and function properly. Everybody in the world has the same gene, so men, women, everybody. And everybody has about 20,000 genes in their DNA, which encode proteins. So your DNA is basically the instructions on how to make proteins, and the proteins are what do the work in your cells in your body. And everybody has 2 copies of every gene, one from mom, one from dad. So that's important in terms of inheritance later on. And the important thing to remember about our genes, our DNA, is that everybody, even though we all have the same genes, the same DNA, everybody has variations in their DNA. And everybody has millions of variations. And so when people have genetic testing, which we'll talk about a bit later on, if we find variations, we place them into different categories. So most of these variations are just common variation. They're benign. They don't cause disease. It's just what makes us all different from each other. At the opposite end of the spectrum are what we call pathogenic variants. So you'll see that word on there. It's also what we used to call mutations. These are gene changes that disrupt how the protein is made and can lead to an increased risk for certain types of diseases. And then we also have a category of variation that we call variants of uncertain significance. And if anybody has had genetic testing in the past, may have seen this on a genetic test report. These are either very rare or very subtle changes in our DNA. So we don't know if they're actually benign or pathogenic. And so this does come up quite a bit. And the reason that uncertain variants come up is that basically when we do genetic testing, we're comparing somebody's DNA to what we consider normal, or our reference sequence. And most, our reference sequence, unfortunately, is mostly data from European Caucasians, because it dates back to the Human Genome Project, which was completed more than 20 years ago. And so there's lots of variation between different ethnic groups in the world. So this is a common finding on testing. In terms of inheritance, so it's important, everybody's got 2 copies of every gene, one from mom, one from dad. Most hereditary cancer conditions are what we call dominant, meaning you just have to have a change in 1 copy of the gene. to have a higher risk for disease. And what this means is that if somebody has a gene mutation, that 50% of their offspring, or 1 in 2, may inherit that change. And so with dominant conditions, we will see people in successive generations who may have that disease. So most hereditary cancer syndromes are dominant. But some of the genes I identified more recently, there are some autosomal recessive conditions. Some pediatric cancer syndromes are recessive as well. And basically what this means is that you have to have a mutation in both copies of the gene to be affected, which means each parent has a change in at least one copy and are what we call carriers. People who are carriers don't have a higher risk for that disease themselves. And so with recessive conditions, we might just see children or sibships affected, or sometimes people will say that something has skipped a generation. It's not necessarily that it's skipped, it's just that maybe a person who's just a carrier has children in the next generation with another carrier. So it looks like things are skipping, but the gene mutations are still there. In terms of cancer genetics, I want to make a bit of a distinction, because all cancer is genetic, but not all cancer is hereditary. And what that means is that all cancer is caused by changes in some of our genes. And as we accumulate these mutations in certain cells over our lifetime, it can cause a cell to grow out of control, and that is what a cancer is. But cancer is only hereditary if those mutations are actually within what we call our germline, which I'll tell you about in a sec, which is only our sperm and our egg cells. And so if the mutation is not in the sperm or the egg cells, you cannot pass these things on. So all cancer is caused by changes in our genes, but only a small percentage is actually inherited or hereditary. And pathogenic variants can be acquired. So most are through things like aging, what we eat, whether we smoke or drink, environmental exposures, behavioral things, medical conditions, sun exposure, and all that kind of things. But inherited pathogenic variants can happen spontaneously, or what we call de novo, and there are some types of specific mutations that are hundreds of years old and have been passed down through lots of generations dating back through time. So there are different. And so one of the things I wanted to point out, because we're mostly going to be talking about hereditary or germline mutations today, but for patients who actually have a diagnosis themselves may sometimes not know that there is a difference. So there's different types of genetic testing. So there's the germline or hereditary testing, which is often done on a blood sample. But a lot of cancer patients nowadays also get what we call tumor genetic testing or somatic genetic testing, looking for mutations within the tumor itself. So not necessarily the inherited side of things, but in the tumor only. And that tumor testing is often helpful or can be helpful for treatment purposes. So there are different types of genetic testing. So it's important to keep that in mind. Sometimes there are tests or research studies where these things go together. But oftentimes, when we're talking about hereditary, we're talking about blood or germline testing only, which is what a genetics clinic or a gen counselor, a medical geneticist would order versus something an oncologist would order. So we're not going to talk about the somatic testing today. We're going to talk about the germline. So I just mentioned that most cancer is not hereditary, so only a small percentage, about 5 to 10% of common types of tumors, so whether it's breast, colon, prostate, pancreas, only about 5 to 10% have a known hereditary cause, meaning we have identified specific genes that if you have a mutation in them, it increases your risk of developing that type of cancer. Most cancer is sporadic, meaning we don't have one single known cause for it. It is, probably hundreds to thousands of different exposures we all have over our lifetime accumulating together. And then in between sporadic and hereditary, we have what we term familial cancer, which is typically a family that has multiple individuals with the same types of cancers, but we don't have a known gene mutation that's causing it. And I'll talk a little bit about familial pancreatic cancer later on. So this could be caused by unknown genes. It could be coincidental. It could be gene environment interactions, but we don't know the specific cause at this time. So when we're trying to assess a family for whether or not they might have hereditary cancer, we are looking for certain features. So if anybody's ever gone to a genetic counselor, they'll ask you lots of questions about your family members, aunts, uncles, grandparents, that sort of thing. So we're looking for people diagnosed with cancers at young ages. We arbitrarily say under age 50. We're looking for people in successive generations with the same or related types of cancer. So it looks like something's being passed down from parent to child. Sometimes people might have more than one type of cancer. So a woman with hereditary breast cancer may have bilateral breast cancer or bilateral kidney cancer, as we can see those things. Some very rare types of cancers in and of themselves are suspicious, like male breast cancer. And then we often ask everybody about their ethnicity because there are some ethnic groups that may more commonly have mutations in certain genes. So an example of this is we usually ask everybody if they have any Jewish or Eastern European Jewish, Ashkenazi Jewish ancestry because they more commonly have BRCA mutations. This is just a quick example of what I was talking about before. So this is a family that has Lynch syndrome. This is a family with hereditary breast and ovarian cancer. So we've got people diagnosed at young ages, related types of tumors. But one of the important illustrations is that if we're assuming all these shaded in people have a gene mutation, it means this person does as well, but they don't have a cancer. So having a mutation in a gene doesn't mean that you have 100% probability of developing a cancer. It just increases your risk above the general population. Same thing over here. This person is unaffected. If it's a breast and ovarian cancer gene, this is a man. And so men do have increased risk, but don't have ovaries and have less breast tissue. So these are the sorts of things that we're looking for when we're assessing a family. A quick background about pancreatic cancer. Some of you may know this, but I'll go through it quickly. What I'm talking about today is specifically pancreatic ductal adenocarcinoma. So this is the most common type of pancreas cancer. There are other histologies of pancreatic cancer that we're not going to be talking about today. More commonly are things like pancreatic neuroendocrine tumors. So I'm not talking about neuroendocrine tumors today, so we're specifically focusing on this. You may see it abbreviated in my slides as PDAC or PDAC. So just want to clarify that this is what I am referring to today. It's a less common cancer than, say, lung, prostate, breast, but in Canada, the risk, lifetime risk is 1 in 76 people, or about 1.3%. Median age is early 70s. It is the 9th and 10th most commonly diagnosed cancer for women and men respectively, and is the 3rd leading cause of cancer death here in Canada. And it is moving up a bit because there are treatments for other types of cancer, such as breast and colorectal, as well as screening. Early detection for those things are getting better. So it is moving up in terms of mortality and diagnostics. Oops, wrong. There are non-genetic risk factors for pancreatic cancer. Most commonly is cigarette smoking. We think it accounts for 20% of pancreatic cancer. Smoking is one of the risk factors that has a lot of good independently validated data from multiple different research groups around the world. There are other risk factors. Oftentimes people ask me about diabetes. longstanding diabetes can be an increased risk, but it's smaller than you might think it is. So it's not a major risk factor. You can have pancreatitis or inflammation of the pancreas. If it is recurrent and becomes chronic, it increases the risk for pancreatic cancer. And this could be due to gallstones, excessive alcohol intake, smoking, that sort of thing. So environmental as well as medical reasons for pancreatitis. And being overweight or having a high BMI increases the risk for many different types of cancer, including pancreas. So I mentioned the genetics. So there are quite a few genes that have been identified that increase our risk for lots of different types of tumors. And the important thing to know about some of these inherited cancer genes is that they don't increase the risk just for one type of tumor. They increase the risk for multiple different types. So there's a tumor spectrum, but there's always a most common or predominant type of cancer that we tend to see with each gene. And so the gene where pancreatic cancer is the most common type of cancer seen, we actually don't know what those genes are yet. And so all of the genes that we currently know about that increase our risk for pancreatic cancer mostly cause other types of tumors. And so it's important to know not just if there's other family members with pancreas cancer, but any other type of cancer, because typically we would mostly see some of these other things. So there are 4 different breast cancer genes that can increase the risk for pancreas cancer, most commonly BRCA1 and 2. There is another gene that works in the same pathway called PALB2. So these 3 genes are high-risk female breast cancer genes, but can also cause ovarian, male breast, prostate, definitely with BRCA1 and 2, probably with PALB2, although the data is not quite there yet. And then ATM is a gene that's been around for a long time, but more recently has been associated with about a 2-fold increased risk for breast cancer. So it's a lower risk breast cancer gene. And it has been studied in a lot of other cancer types, including pancreas, but because it's a newer association, the data and validation with ATM is less than it is with the breast cancer. So it is on our panels, but we still need more research about ATM. There are several colorectal cancer genes that can also increase the risk for pancreas cancer. So Lynch syndrome is a hereditary colorectal cancer condition that also increases the risk for uterine cancer. We can see lots of other GI types of cancers, including pancreas, biliary, small bowel, stomach. We can see urinary tract cancers. So there are 5 different Lynch syndrome genes. This gene, STK11, causes an extremely rare syndromic condition called Peutz-Jeghers syndrome. It's very uncommon. I've been working with the GI genetics group for 17 years, and that registry has been established for over 40. And I think there's only about 50 families identified with STK11 mutations in the last, or that we have in the registry. So it is uncommon, but it definitely increases the risk for pancreas. The CDKN2A gene, it mostly causes familial melanoma, but it is also a high-risk pancreas gene. There is a very rare inherited gene mutation in this gene called TP53. If it is inherited, it causes something called Lee-Fraumeni syndrome, which mostly causes hereditary childhood tumors, so leukemias, brain tumors, sarcomas, very early onset breast cancer, but can increase the risk for pancreas. Sometimes patients may know this. I get questions quite often about them finding TP53 mutations in the tumor cell, so somatic tumor testing. TP53 is an extremely common gene that is mutated in almost all solid tumors. So if you see this on a tumor report, it's very unlikely to be inherited. And then just quickly, these are the 2 most common pancreatitis genes. There are some others. The pancreatitis genes are a bit different than all these other ones, which are what we call tumor suppressors. These genes in and of themselves don't increase the risk for pancreas cancer, but if you have a mutation in one of these genes and you get chronic pancreatitis because of that, it's that that inflammation damage from the pancreatitis that then increases the risk for pancreas cancer. So in and of themselves, these don't cause pancreas cancer unless they cause pancreatitis preceding that. There's lots of different risks that I'm going to go through in the next slide. And then again, we still need better validation on some of these genes. So again, I'm going to ignore the pancreatitis one. Again, it only increases the risk if you actually get chronic pancreatitis associated with it. And if you do have chronic pancreatitis, whether it's hereditary or non-hereditary that we talked about before, it can significantly increase your risk for pancreatic cancer. In descending order, in terms of risk, that very rare condition, Peutz-Jeghers syndrome, has the highest risk for pancreas cancer. It's estimated to be above 20%. The second highest risk is for the melanoma gene, estimated to be around 17%. This is data based specifically on a common Dutch mutation, but we routinely or give risk of about 15 to 20% for CDKN2A mutation carriers when we find them. So these are the highest risk, but they're very uncommon. The genes people often think about are BRCA1 and 2 and PALB2, which are those breast cancer genes again. There is an increased risk for pancreas cancer, but it's actually lower than some people might think or that have been estimated before. So this is a paper that came out in just earlier this year and is data from over 3,000 BRCA carriers that show about a 2 to 3% lifetime risk for pancreatic cancer with mutations in those genes. Same thing with PALB2. This is from a nice PALB2 consortium that has data on over 500 families with PALB2. So lower risks. The Lynch syndrome genes, there's not good data out there to estimate the specific risk for each one of the genes because there are 5 different ones. MLH1 and MSH2 are the highest risk in terms of things like colorectal and uterine cancer. And then MSH6 and PMS2 are lower risk genes. So oftentimes when papers are reported, all of these genes are grouped together, even though we know the risks are different. And then the best data that we have about risk with Lynch syndrome is from this nice worldwide consortium that has data on over 6,000 Lynch syndrome carriers. But because the pancreas risk and some of the other upper GI cancer risks are so low or so uncommon, it's all just grouped together. So we don't have great organ-specific, gene-specific information for each one of the Lynch genes, but it is increased. And then again, ATM, this newer gene, this is a paper that was published. We're part of this, Dr. Gallinger's group is part of this, published last year. This looks really high. I put a star next to it because this is not right, which goes back to me saying that we still need to validate a lot of this risk. The reason I don't think this is correct, even though it's data from our consortium, is that our consortium that they pulled the data from is from a group that collects data on what we call familial pancreatic cancer. So in and of itself already has multiple family members with pancreas cancer. So I think this is very overestimated. So I would actually ignore this. We still just need better data. And because TP53 inherited mutations are so low, we don't have a penetrant or a risk estimate for that gene. So I'm going to show you a bit of what our data we have from the University Health Network, so Princess Margaret and Toronto General here in Toronto. just in general, what's been published in the literature. So again, only 5 to 10% of most cancers are hereditary. We published the first prospective study in pancreatic cancer looking at BRCA1 and 2 in 2015, and we found about 5% of pancreas cancer has BRCA mutations. There are some common Ashkenazi Jewish mutations that increases our likelihood of finding a mutation if you're Ashkenazi and have pancreas cancer from 5 to 12%. And then what's been published in the literature is ATM seems to be a bit more common, and everything else is probably less than 1%. So our data that we have this is data from the last 3 years. So in the last 3 years, I've tested 707, well, I have results back on 778 people. We're probably over 800 now with pending results. And our overall detection rate is 5.7%. So right on that 5 to 10% mark. ATM is our biggest pickup rate at 2%. And something strange that we've noticed is our BRCA detection rate is lower than what we had published 10 years ago. Not really sure why this is. I will have to come up with some sort of explanation, but maybe we'll get more carriers next week or something. And then again, PALB2, all 5 Lynch genes, CDKN2A, TP53, and SDK11 are quite rare. Pickup rate is less than 1% if you have a pancreas cancer, so quite low. And I'll just go through this quick. You know, as I think the important thing to know is as genetic testing is becoming more widespread because our technologies are getting less expensive, testing has expanded to those without family history. So we are finding more mutations in people who don't have a family history. So even if you don't have multiple female relatives with early onset or multiple breast cancer or male breast cancer, you likely can still have genetic testing. So this is just a family that looks consistent with BRCA, as opposed to this is another family that we did testing in that is very large, lots of brothers and sisters, lots of aunts, uncles, found a BRCA2 mutation and there isn't a single breast cancer reported. So even if you don't have a family history, it doesn't mean for certain that we won't find something. Just touching briefly on familial pancreas cancer, because we get lots of referrals for genetic testing for this as well. The definition is that you have 2 first-degree relatives, so parents, siblings, or a child with pancreas cancer, 2 or more. And this is actually more common than you might think. So it's 10% of all new pancreas diagnoses will meet this criteria. So if you are diagnosed with a pancreas cancer, 10% of those people will have a first-degree relative who also had pancreas cancer. So it's not uncommon. And Dr. Gallinger and our groups downtown, along with other people in the country and all over the world, have collaborations and have been looking to identify the gene where pancreas is the most common. But not all families are the same. So if you do have, a parent and a child with pancreas cancer, it could be a gene we don't know yet. It could be shared environmental factors. It could be coincidental. Maybe both were heavy smokers. Maybe they're both diagnosed quite late. So, but we do think there are some genes because we do have families where people are diagnosed very, very young in their 30s, 40s, multiple generations, all confirmed to be pancreas adenocarcinoma. So not all FPC is the same, and we definitely think there is a gene, but we haven't identified the major gene yet. And this is a question that we get a lot too. If you have a close family member or even a more distant family member with a pancreas cancer, what is your risk? And so this is some data. It is from 2009, so I'm hoping there can be updated estimates before, but if you have one first-degree relative, which again is a parent, a child, or a sibling with pancreatic cancer, your risk is elevated, but that's true of any cancer. So if you have a close family member with breast or colon or prostate, your risk is elevated just because of the family history. So with pancreas cancer, your risk is, this says estimated to be 6%. That might be a bit high. If you have one grandparent or anybody beyond a first-degree relative, it doesn't increase your risk very much. So the farther you get away removed from somebody with a pancreas cancer, the more average your risk becomes. And then your risk does increase with the number of close family members. So if you have a parent and a sibling, it's even higher. If you have 3 or more, it's quite high. So depends on degree of relationship and number of relatives. So quickly, genetic counselors, I'm a genetic counselor. We are part of the healthcare team. We have special training with a master's degree program to talk to families about how inherited diseases and conditions could affect them, guide them on what the best testing is and what results actually mean, how to make informed choices. We work in varied clinics and settings. So we work in industry, in labs, in research, in education. And so you might find genetics clinics or genetic counselors in a general genetics clinic, or very specialized genetic counselors like myself that I work specifically with our HPV group. So you will see us everywhere. Our roles are expanding. And I think more and more people are becoming aware of what genetic counselors are, because I think when I trained 20 years ago, nobody knew what a genetic counselor was. So I think people are being more informed. So that's great. So if you are referred for genetic counseling, what's going to happen? So the first thing is they are going to take your personal, medical, and family history. So it's important to know about your family history. Like we mentioned, we may ask to track down medical records on the cancers reported in the family. Family history reports are not all the same, and they're often not accurate. If somebody tells me that their uncle had a pancreas cancer at 30 and survived 50 years, I might be a bit skeptical and try to get records, because maybe it's not pancreas adenocarcinoma, maybe it's something else entirely. So it is helpful to confirm cancer diagnoses. We'll do education about genetics, options of what is available for genetic testing, whether somebody is even eligible to have genetic testing, information about other cancer screening, prevention options, and discussion about inheritance. I think the important thing to remember about genetic counseling is you can speak to a genetic counselor. It doesn't mean you have to go through or follow through with genetic testing. And then the flip side of that also is you can request to be referred to a genetic counselor, but it doesn't mean that you will get genetic testing, because most provinces do have eligibility criteria and not everybody meets them. So even if you are referred to genetics, doesn't mean you necessarily will get genetic testing. And the reason I say that is testing is most informative when it starts on somebody who has the disease in question. And so for this talk, we're talking about pancreas cancer. The reason it's best to start on that person is we know they're affected, and it gives context when interpreting results for other family members. And this is just an example of what I mean from this. So this is a family that was referred to us in the past. It was this person who did not have a cancer diagnosis themselves, referred because their father had pancreas cancer, their sister had a breast cancer at 52 and a pancreas at 70. They were of Ashkenazi Jewish ancestry. And because of their ethnicity, they were eligible specifically to test just for the Jewish BRCA mutations, which was negative. But because it's negative, it actually doesn't tell me anything, because I don't know if this is because If we tested this person, we wouldn't have found anything anyway, because again, the pickup rate's very low, 5 to 10%. Or if we would have found a mutation, oops, and I just gave you the answer. If we would find a mutation, and then this person didn't inherit it, which means their risk for pancreas cancer is no higher than anybody else's. So even though we did testing for them, we recommended the sister go get tested, and she did have a BRCA2 mutation. And so now these negative results are informative. He didn't inherit what's likely causing both of these, pancreas and the breast cancer. And so we don't expect this person to have a higher risk for BRCA related cancers. And so if we had just had negative results on somebody who's ineffective, it's not true negative, it's just uninformative. It doesn't really tell you anything. So who in Canada with pancreas cancer is eligible for testing? The good news is most everybody. So I spoke to genetics clinics in all the provinces here in Canada. And so if you live in BC, Alberta, or Ontario, anybody who's diagnosed with a pancreas adenocarcinoma, regardless of age, regardless of family history, is eligible for genetic testing. And excuse me. In Saskatchewan, there are no specific guidelines, but the genetics clinic in Saskatoon accepts all referrals, but testing depends on the discretion of the clinic once they get more information about the history. In Manitoba, unfortunately, you can be referred, but you need to have a family history that is consistent with one of those known genes. So a family history of breast or ovarian, melanoma, Lynch syndrome, something like that. But could still be referred for adjunct counseling for an assessment. And then out east, so in Quebec, the Maritimes, and Newfoundland and Labrador, there's no specific provincial guidelines, but they all said that if a pancreas cancer a patient was referred to genetics, they will accept it and will do the testing for them. So pretty widespread. In terms of, there's no genetics clinics in the territories, but BC covers the Yukon, Alberta covers the Northwest Territories. I actually couldn't get any information about who's covering Nunavut because it's so large. Part of it's about Quebec and Manitoba. So what I would reach out to somebody local there, but most likely whatever province covers that part of the territory would be the same for the 3 territories. In terms of a genetic testing referral, if you have a pancreas cancer and you are having treatment, or if you're not having treatment, or you finished your treatment, ask your treating physician or your family physician to refer you to a local genetics clinic, because most likely you will get testing. Know your family history. Like I said, ask family members about what types of cancers they might have had, ages of it, diagnosis. Very important is find out if anybody in your family has already had genetic testing. That's very helpful to know. Again, provincial coverage differs. There are sometimes out-of-pocket testing options. I can take questions about that. I wouldn't necessarily recommend that, but if somebody isn't covered, that could be a criteria. And even if somebody doesn't meet criteria, there could be research to participate in, which is sometimes helpful. We're getting close. Benefits of genetic testing. There are some genes that can impact treatment, different drugs approved by Health Canada. There's surveillance for other cancer risks for family members. I'm going to go quick because we're running out of time. This is a question I get a lot. Dr. Gallagher and I get several referrals every single week for unaffected family members asking us about testing. Again, oftentimes we don't test unaffected family members, but they're also asking about pancreatic cancer screening. Unfortunately, at this time, there is no imaging or blood testing that is known to find pancreas cancer at its earliest stage and reduce mortality from it. So we do not give clinical pancreatic cancer screening recommendations in a public healthcare setting because we're all overloaded, and we don't think it's a proper use of healthcare dollars for tests that don't work. There are international guidelines that acknowledge that screening for pancreas cancer is ineffective, and anything that is done needs to be done under research protocol. Different countries and provinces have different recommendations, so you can always check. I'm only speaking for Dr. Gallinger and myself here at UHN. We are part of a large collaborative study called PRECEDE. It stands for the Pancreatic Cancer Early Detection Program, which is this massive collaboration with dozens of sites in the States. There's 3 here in Canada. They're opening in Europe, Israel, Asia, Australia. And basically, we're trying to enroll as many patients as possible who are either FPC or have a gene mutation, and doing the same consistent screening and getting long-term outcome data. There are sites in Canada. So Dr. Gallinger, I here at, at UHN and Mount Sinai, we are not enrolling every single person referred. Right now, we are only enrolling our highest risk mutation carriers. So that CDKN2A, that melanoma gene, or Peutz-Jeghers. We are not enrolling BRCA, FPC, anything else right now. We are working on more funding and capacity, but we just don't have that right now. In Montreal, Dr. George Zagopoulos and his gen counselor Adeline are enrolling at the BC Cancer Agency in BC. Inton Schrader, who's a medical geneticist, and her gen counselor Carol Kremen are part of PRECEDE as well. So if you live in those provinces, you can be referred to them. And this is how you find a genetics clinic. So if you have pancreas cancer, you can go to the Canadian Association of Genetic Counselors website. Right on the homepage, there is a link that says search for a genetics clinic. You can put in your province or your city and find one close to you. If you have family members that live in the states who have a diagnosis, you can go to the National Society of Genetic Counselors, which is the American version. On their homepage, there's a link that says find a genetic counselor. You can type in the zip code and pull up genetic counselors close to them. So there are resources. I would recommend if anybody has a diagnosis or a family member with a diagnosis that you could get them referred to genetics.